to our second edition. Today, our presenter is Professor Margaret Rees, EMAS Executive Director, with the topic Managing Menopausal Symptoms, and we hope that you will like her presentation. Please, Professor Rees, when you want.
Thank you very much. I'm talking about managing menopausal symptoms because they are the commonest reason that women will seek advice from a health professional. Menopausal symptoms include vasomotor symptoms such as hot flushes and night sweats, urogenital symptoms such as vaginal dryness, musculoskeletal symptoms, effects on mood, and sexual difficulties, and I will be talking about the first two. So, when can women expect to have symptoms and how long will they last for? If apparent and well documented that women can experience hot flushes for many years, as shown in the SWAN study and the Penn ovarian aging study. In the SWAN study, women who were premenopausal when they first reported hot flushes had the longest total duration, with a median of more than 11 years. And persistence after the last menstrual period with a median of 9.4 years. Hot flushes may last longer in African American women. The Penn ovarian aging study cohort found that 1/3 of women at 10 years or more after menopause continued to experience moderate to severe hot flushes. African American women and obese white women had significantly greater risks of hot flushes compared with non-obese white women. Urogenital symptoms last lifelong, so it is a chronic condition. They affect 1 in 2 women or more, and symptoms often come back when treatment is stopped. So, what are the options for vasomotor symptoms? Lifestyle, such as exercise and weight loss, estrogen-based therapies, non-estrogen-based prescription therapies, alternative and complementary therapies, and cognitive behavioral therapies. And I'm going to talk about the first 3. This National Health Service UK website recommends the following lifestyle modifications for menopausal symptoms such as hot flushes and night sweats: regular exercise, weight loss, wearing lighter clothing, sleeping in a cooler room, reducing stress, and avoiding possible triggers. And I'm going to look at the evidence regarding exercise and weight loss. So, Elavsky undertook a 15-day study of exercise, and they found that moderate aerobic exercise decreased objective and subjective hot flashes 24 hours after exercise. But in women with lower fitness levels, more daily moderate physical activity led to more self-reported symptoms. Sternfield and colleagues undertook a randomized controlled trial lasting 12 weeks. They found that 12 weeks of moderate intensity aerobic exercise did not alleviate vasomotor symptoms, but could result in small improvements in sleep quality, insomnia, and depression. It is therefore not surprising that a Cochrane systematic review concluded that the evidence was insufficient to show whether exercise is an effective treatment for vasomotor menopausal symptoms. Therefore, Amanda Daly and colleagues, and I was one of them, undertook a free-group, randomized, controlled 6-month trial of 2 exercise interventions and a control group. And we found that exercise was not an effective treatment for hot flushes or night sweats. We therefore concluded that, contrary to current clinical guidance, women should not be advised that exercise will relieve their vasomotor menopausal symptoms. So turning to weight loss, Huang undertook a 6-month randomized control trial of an intensive behavioral weight loss program versus a structured health education program in women who were overweight or obese and had urinary incontinence. They found that among women who were overweight or obese and had bothersome hot flushes, an intensive behavioral weight loss intervention resulted in improvement in flushing relative to control. However, I would say that the effect was modest in that there was no change in symptoms in over a third of women, and in some there was worsening. Looking at the effects of bariatric surgery, and here menopausal symptoms were assessed at the preoperative and the 6-month postoperative visits, it was found that the degree of bother of symptoms associated with hot flushes among midlife women may decrease after bariatric surgery. However, the situation might be slightly more complex, as shown in the WHI dietary modification trial. The dietary intervention was designed to reduce fat intake and increase intake of fruit, vegetables, and whole grains. They found that women who lost weight reported a reduction or elimination of vasomotor symptoms over 1 year. However, women in the intervention who gained more than 10 pounds also had reduced vasomotor symptoms, suggesting that the beneficial impact of healthy diet was not restricted to those who lost weight. The authors concluded these results support the use of weight loss and healthy dietary change as alternative approaches to hormone therapy for the relief of vasomotor symptoms. What about estrogen-based therapies? And I'm going to look at 3 issues: the minimally effective dose, stopping HRT, and using HRT in women over the age of 65. People have been looking at the minimally effective dose for a very long time, and one of the first publications was by Morris Natelovitz in 2000. So this was a randomized, double-blind, placebo-controlled 12-week study of 0.25 milligrams, 0.5, 1 and 2 milligrams of oral micronized 17-beta estradiol or placebo. They found a dose-response effect for reducing moderate and severe hot flushes and concluded that 1 milligram appeared to be the most useful initial dose. Subsequent studies have been supportive of 0.5 milligrams. For example, this study by Nick Panay and colleagues, where it's 0.5 milligrams of estradiol and norepinephrine, and that by David Archer, where it is 0.5 milligrams with combined with drospirenone. The minimally effective dose has been looked at as well with transdermal 17-beta estradiol by Gloria Backman and colleagues, and they found that 14 micrograms per day was clinically and statistically significantly more effective than placebo in reducing the number of moderate and severe hot flushes. What about stopping treatment? The main issue is that it is impossible to predict whether individual women will still be symptomatic or not when they stop systemic hormone therapy. The limited evidence available shows no advantage of tapering down or stopping abruptly. Anecdotally, older women need less estrogen to control their symptoms, and thus a lower dose can be tried before stopping. So this supports the idea of tapering so that you can find the minimally effective dose for that individual woman. What about using hormone therapy in women over the age of 65? The global consensus statement said benefits are more likely to outweigh risks for symptomatic women before the age of 60 years or within 10 years after menopause. But as I described earlier, women can suffer from hot flushes for a very long time. Therefore, the North American Menopause Society, NAMS, published a statement on continuing use of systemic hormone therapy after age 65. They concluded that the use of hormone therapy should be individualized and not discontinued solely based on a woman's age. The decision to continue or discontinue hormone therapy should be made jointly by the woman and her healthcare provider. What about non-hormonal management? 2015 has seen two position statements, one by EMAS and the other one by NAMS. And I'm going to discuss the evidence regarding SSRIs, SNRIs, gabapentin, clonidine, and stellate ganglion blockade. So a variety of SSRIs have been looked at in clinical trials, and they are effective in decreasing both frequency and severity of hot flushes. In 2013, the FDA approved paroxetine to treat moderate to severe hot flushes. However, it should be avoided in tamoxifen users as it affects tamoxifen metabolism to the active metabolite. Paroxetine is a cytochrome P450 2D6 inhibitor. And this study by Kelly et al., published in 2010, looked at the risk of breast cancer mortality associated with increasing proportion of antidepressant use during tamoxifen treatment. And this shows that paroxetine should be avoided, but venlafaxine appears to be safe. A question that is often asked is comparison of the effects of non-hormonal therapies with low-dose estradiol, and this is a randomized control trial comparing both. So it's a randomized double-blind treatment with 0.5 milligrams of 17-beta estradiol versus 75 milligrams of venlafaxine or placebo for a total of 8 weeks. The authors concluded that low-dose oral estradiol and venlafaxine were effective treatments for vasomotor symptoms in women during midlife, while the efficacy of low-dose estradiol might be slightly superior to that of venlafaxine. The difference was small, and the authors considered this of uncertain clinical relevance. The next issue is non-hormonal strategy effective over a long period of time? So this is a 1-year study of venlafaxine in a randomized controlled trial setting. and the investigators found that the treatment efficacy of venlafaxine 100 milligrams a day achieved on week 12 in postmenopausal women with vasomotor symptoms was maintained at 1 year. What about gabapentin? Gabapentin is indicated for epilepsy and neuropathic pain, and it reduces hot flushes by about 50%. It is not an approved treatment for hot flushes. One of its advantages is that it does not inhibit cytochrome P450 and can be used in women taking tamoxifen. Clonidine was originally developed for the treatment of hypertension, and it is licensed for the treatment of hot flushes in some countries such as the UK. Meta-analysis says that it is modestly more effective than placebo. Again, it can be used in tamoxifen users as it does not inhibit cytochrome P450. What about stellate ganglion blockade? There have been a variety of case control studies, but last year was published a randomized controlled trial in 40 women. It was found that there were no significant group differences in overall vasomotor symptom frequency, but the frequency of moderate to very severe hot flushes was reduced more in the active group compared with the sham group. The authors concluded that a larger trial was warranted to confirm these findings. What are the options for urogenital atrophy? Starting with topical estrogens, the UK NICE guidelines published last month said offer vaginal estrogens to women with urogenital atrophy, including those on systemic HRT, and continue treatment for as long as needed to relieve symptoms. Then there are lubricants and moisturizers, aspermethine, and laser therapy. The North American Menopause Society recommends that non-hormonal vaginal lubricants and moisturizers should be first-line therapies for women with vaginal atrophy. Moisturizers are typically used on a regular basis. Lubricants tend to be used episodically associated with sexual activity. Women with vaginal dryness can use moisturizers and lubricants either alone or in addition to vaginal estrogens. Aspermethine is a selective estrogen receptor modulator, so it is a SERM. It is approved both in the USA and Europe. So oral aspermethine is indicated for the treatment of moderate to severe symptomatic vulvovaginal atrophy in postmenopausal women who are not candidates for local vaginal estrogen therapy. Like other SERMs, the risk of VTE is increased with the use of aspermethine. Thus, its use is contraindicated in women with an active or past history of VTEs, including deep vein thrombosis, pulmonary embolism, and retinal vein thrombosis. So lastly, what about the use of laser therapy? Short-term data regarding the use of laser therapy has reported improvement in vaginal epithelium morphology and symptoms, and therefore appears to be a non-hormonal therapeutic modality. So the results are encouraging. However, we need more controlled studies with long-term follow-up to provide data to find out how this new treatment can be used for long periods of time, since aging women can have symptoms for several decades. So I would like to conclude by saying I would like to see you in 2017 at the 11th European Congress on Menopause and Andropause in Amsterdam.